So this is Unit 8, Neoplasms. Neoplasms, otherwise known as tumors or cancer, is one of the leading causes of death in Canada. About 42% of people who develop cancer will be dead within 5 years, so 58% will be alive. It is a very important class of disease that we will see a lot. You will see a lot through the course of your career, and most of us will have, it will touch our lives through family and friends. So the goals for this are to describe neoplasms and the various types of neoplasms, list signs and symptoms of cancer in general, describe some tests that we use to discover cancer. More important is how does cancer develop and how does it spread, because these are the ways that our understanding will fuel treatments and future treatments. Explaining the current treatments, some of them, and describe various types of cancer. This is really an overview of it. So this YouTube link is to a presentation on cancer, and it's worth a watch. It definitely is informative. It's not done by us, but it is worth a watch, very informative. So there's all kinds of different types of cancer, and you will hear about it, and lay people just think it's one sort of thing. But there's cancers that are benign, cancers that are malignant, cancers that are of epithelial origin, cancers are of other tissue origin. And they're all treated differently depending on where they are, what they're made from, how far along they are, things like that. We'll be discussing that throughout the course of this presentation. So really, to understand cancer, you have to realize that what it is cell differentiating gone wrong. So when we are first conceived and we're 1 cell and 2 and then 4 and 8 and 16 and 32 cells, all the cells are pretty much the same. And then as the embryo grows and then becomes a fetus and then becomes a person, all the different tissue types, all the different cell types grow from that original cell. And we talked about this in physiology previous semesters. So, but the concept is that cells differentiate, and they're differentiated depending on the environment that cell finds itself in, by the surrounding cells, by chemical means, and all kinds of things. And the cell differentiation, the specialization of the cell, really is programmed by the organism. But every now and then the programming goes awry, and cells don't differentiate properly. They don't become a normal part of the tissue. If the life cycle is disturbed and they don't end up going through a long enough interphase before the next mitosis, it can be a problem. They'll lose their specialized functions, or they will mistake their functions and start to differentiate into inappropriate things. And all of these things really are neoplasm, new growth. neoplasm. So neoplasm is a tumor. It is primarily cellular, but it's cells growing out of control. Either the rate of growth is out of control, or they are reproducing inappropriately. Normally, interphase is when the cell does its work. It can't do protein synthesis while the chromosomes are condensed and it's in the mitotic phases. These cells in a neoplasm are reproducing so quickly that they really don't have enough time to develop their organelles, to develop the proteins that they're supposed to, and their functional usefulness disappears. The growth happens so quickly that it will outstrip the rest of the tissue's nutritional requirements and start demanding the lion's share of, because a lot of resources have to be put into growing a tumor. The cells become more and more abnormal because they are reproducing at a rate that doesn't allow them to grow enough organelles or to grow the appropriate intracellular mechanisms. And so the cells become more and more abnormal, and they start looking more and more immature. There are as many different types of tumors as there are tissues. But almost all tumors, because of this excessive growth, get big. And in getting big, they take up space and they exert pressure on other structures, surrounding structures, and can maybe limit, for instance, blood supply to those structures or just the functioning of the surrounding structures, and can become a problem just in and of their space taking. Now, there's a couple of different types. We talk about malignant tumors, and we can talk about benign tumors. So the benign tumors really are cells that are differentiated, but they are reproducing at a really fast rate. Typically, they're encapsulated. The tumor itself has very defined margins. So it's a little locus of cells that are growing out of control and getting bigger and bigger and bigger. But as the cells reproduce, they stay attached to one another, and so the tumor itself, the edges of the tumor, are defined. Now, benign tumors are benign in that they don't metastasize, and they usually don't produce a lot of the paraneoplastic syndromes and things like that, which I'll talk about later, but they are not life-threatening in and of themselves. However, they can be life-threatening in the space they take up. My receptionist's niece just last week had a benign tumor removed from her cerebellum, and it was threatening her life because it was growing at such a rate that it was putting pressure on the brain and causing dysfunctions because of the space, but not because of the physiology of the tumor itself. Malignant tumors, the cells become undifferentiated and they become non-functional. They are growing at prodigious rates, but it's non-functioning tissue. It will break apart. It tends to not be encapsulated. It tends to be growing it invades the surrounding tissues. It often spreads to new areas, either through the tissue into the next tissues, or it can go via blood or lymph, etc. Again, we'll talk about this more. And these tend to be life-threatening. These are the things when somebody says, oh, that person was riddled with cancer. That's what they mean. Now, we don't tend to call benign tumors cancerous. It's the malignant tumors that are cancerous. The word cancer is reserved for that. So they will probably kill the host if left untreated. You know it's malignant if it metastasizes or invades surrounding tissue. It starts in a specific tissue, but it doesn't resemble the tissue that it comes from. There's quite a bit of anaplasia. And the more anaplasia there is, the more aggressive the malignancy. So anaplasia is inappropriate growth. It's lack of differentiation. So sometimes these things grow so fast that they outstrip their ability to have nutrients in their center, and they often become hollow and necrotic. They're always dysfunctional if it's malignant. So here's two smears, pap smears. The one on the left is normal, and the ones on the right are cancerous. They're anaplastic. And so you'll see that these cells are large and they have discrete nuclei that are fairly small. They're flat, so these are the typical cells. These ones, you'll see that the cells are all different sizes. They're reproducing. You'll notice that a lot of them are actually have the chromosomes here all condensed, so that indicates that a lot of these cells are actually actively going through mitosis. And that's important because when we talk about treatment, that's what most of the treatment is targeting, the cells that are actively in mitosis. So benign tumors really, as the tumor itself doesn't potentially kill the host, but it could be life-threatening because of its location. So, for instance, if it was on a major artery, or in the say it was in the pericardial sac or something like that, it could affect the working of the heart. Usually they're encapsulated. They resemble the tissue. The growth is usually more slowly. They rarely go necrotic. Oftentimes, they even retain their original function. So these would be things like lipomas and things like that. You'll see these on people. These are little fat tumors. In the nomenclature of this, we use OMA to indicate a benign tumor, and carcinoma or sarcoma to indicate a malignant tumor. So carcinomas are when the original tissue is epithelial, and this is the more common type of malignant cancer because epithelial tissue is very, very highly mitotic. There's a lot of cells, and they're undergoing mitosis on a regular basis because we replace epithelium often, because it's the boundary, it's the covering and lining tissues. And so there's more, because it happens more often, there's mistakes happen more often, and it's the mistakes that become the tumor. Sarcoma is a malignant tumor of mesenchyme, muscle tissue or connective tissue. Bone, for instance, is a connective tissue, and so if there's a bone tumor, it's a sarcoma. It's like an osteosarcoma. Leukemia is a bone marrow thing. It's a malignant growth of white blood cells. So something like a lipoma is, because it doesn't have the carso or sarcoma part, lipoma is a benign tumor of fat, lipids. So these statistics here are from 2013, but there hasn't been much change. It's someplace around 200,000 Canadians diagnosed each year with cancer. 2 in 5 people will develop cancer in their lifetime. That's quite a bit. That's 40% of people. 1 in 4 people die of cancer. That 25% of people who die of cancer in Canada. So it's saying about 838,000 alive at the beginning of 2009 were diagnosed 10 years before. There's a 63% likelihood of Canadians with cancer surviving 5 years relative to the general population. So you get a cancer diagnosis. It's not a death sentence, but it's like basically a 1/3 worse chance of dying from it. So here's the leading cause of death, with almost 30% of deaths in Canada. And if you look at this, you'll see that 1 in 4 is 25%, almost 30%. These things are, take it with a grain of salt, but it's in that neighborhood, between 25 and 30% of people who die in a given year die of cancer. Usually it's older people. 40 to 45% of people in their lifetime, a little bit fewer women, a little bit more men. It's probably lifestyle things and occupational things. Also, it's probably got something to do with women are much more likely to seek health care and do something about it than men are. Men tend to be stubborn about this. 5-year survival rate, about 66%. The relative survival rate are the highest for thyroid cancer and prostate cancer and testicular cancer. They're the lowest for pancreatic cancer, esophageal cancer, and lung cancers. If you look at that pancreatic cancer, it's 8%. Now, there's a lot of theories as to why that is. One of the things is it's usually very far gone and well developed before any symptoms appear, and therefore it's less treatable. Things like thyroid cancer give you symptoms very early, so it's an earlier detection, and so is more treatable. The same thing with prostate cancer. We do a lot of screening for prostate cancer. You know, esophageal cancer, and lung cancers, people have a cough. They've been smoking for years, they have a cough. And so the cancer has given them a little bit more of a cough, and they discount it. They don't realize that those are symptoms. Same with esophageal cancer. You get heartburn. I eat 2 times a day, and so now I'm up to 3, is kind of the attitude. So it's far along before there's an intervention. And so therefore, more people die from it. The 5-year survival rate is lower because of this. So here's a breakdown. So I find it interesting. Prostate cancer is about 25%. Breast cancer is about 26% of women. Lung is about the same, 13 and a bit. Both colorectal in the relatively the same area. Men a little bit more. Bladder cancer is higher in men. It doesn't even appear on the women's side. Thyroid, non-Hodgkin's lymphoma. You'll see that melanoma is someplace in about that 3%. That's from sun. I'm not expecting you to memorize this, but just to familiarize yourself with this. So you'll see that lung leads the death rate on both men and women. Colorectal is pretty high. Prostate and breast, pancreatic cancer. You'll see that they're not far off between men and women as far as raw percentages go. Cancer research claims that about 1/3 of the major cancers can be prevented through exercise, diet, and body mass index. So lifestyle factors. I mean, when you think about it, the leading cancers, lung cancer, it's a lifestyle thing. It comes from smoking and maybe industrial fumes and things like that. You look at pancreatic cancer, probably has got a lot to do with diet, things like that. So healthy lifestyle is the key to prevention. Unfortunately, once it develops, you can't reverse it by deciding, well, now I'm going to quit smoking and lose some weight and get some exercise. This is preventative. It's beforehand. It's why education is key. Malignant tumors often become very difficult to treat because they actually will grow blood vessels into the tumor itself, and the tumor will be nourished by the body. And we call this angiogenesis. It's growing new blood vessels in order to supply the tumor itself. Usually by the time a tumor has its own blood supply, it is late stages. We don't really know why it happens, but we do know that when it happens, it's not a good sign. This is the tumor becomes much, much harder to deal with once there's a blood supply, both surgically and chemically. So when a tumor is discovered, inhibiting the angiogenesis is really an important goal, to limit the growth of the tumor. It's like cut off its blood supply. Don't let it establish an independent blood supply, and that will limit the growth. So I've already kind of mentioned this. So when we name tumors, we use OMA as to indicate whether it's benign, or sarcoma or carcinoma if it's malignant. We usually include the tissue of origin in the name. So there's tables in your textbook of this, but it makes a certain amount of sense. Right? So adeno means gland. So an adenoma is a glandular tissue, a benign glandular tissue. An adenocarcinoma is a malignant tumor of glandular epithelium. That's why it's carcinoma. Okay. So a chondroma is a benign growth of cartilage. A chondrosarcoma is a malignant one. Urethral is red blood cells. Hemangio is blood vessels. Hepatos, liver. So like a hepatosarcoma, right? A lipoma, I've already mentioned, is fat. So a benign fat growth is a lipoma, right? Lymphoma is in the lymphocytes, oftentimes in a lymph node. So melanomas are in the pigment cells. Now, this is one of the places where it breaks down, because a melanoma is a malignant tumor, even though it doesn't say melanocarcinoma. Myeloma is in the bone marrow. So there's a cancer called multiple myeloma that's a bone cancer that is in the marrow. Myoma is in the muscle. So a leiomyoma is in the muscle of the uterus. Osteomas are in the bone, so benign tumors are osteomas. Osteosarcoma is a malignant tumor of bone, of osseous tissue. That's what Terry Fox had, was an osteosarcoma. So these rules are general. There are exceptions to them, as in melanoma, but it's cool. So a fibrosarcoma is a malignant tumor of fibrous connective tissue. Okay. So a neuroma is neurons, and it's usually benign. So a chondroma is of cartilage. Tumor of bone would be an osteoma. So there's a tumor of bone called the osteoid osteoma, which is of the osteoid. There are other bone tumors that are benign as well. So if we look at how tumors grow, the first thing that happens is the normal cellular control mechanisms lose control. And the surface antigens, there's something like the receptors on the surface of the cells start to not be correct for a number of reasons. It could be a genetic variation within the cell itself. It could be a number of things. But when they lose control, we get this increased cell division. So mitosis starts happening more quickly than it should. And then that growth leads to compression of adjacent tissues and usually inflammation because the adjacent tissues start to get damaged. And then the inflammation causes more cellular proliferation because that's one of the things that inflammation does. And so cells kind of probably will start to lose their cohesion. If the tumor gets too large, then the central part of the tumor will start to get necrosis. The cells die because they're too far away from their nutrients. If it's a malignant tumor, you'll probably get an angiogenesis, and blood supply will go to the center of the tumor, and then it will continue to grow. And then metastasis is when it spreads to new regions from that primary location. And that's can become very dangerous, very difficult to treat once you get metastasis. So here's a picture of it. So benign cells will grow locally. They don't spread by invasion or metastasis. They just stay put. They grow around their central locus. If a malignant tumor will start to invade neighboring tissues, erode into the blood supply, maybe get angiogenesis, in which case the cells will break off and pass through the blood supply. They'll pass through the lymphatics and can start to spread to other parts of the body. So this started out as this cell here having a problem, and then growing and multiplying and turning into this, and then etc. It gets bigger and bigger until this tumor has now invaded other tissues and is now spreading via the blood supply in this particular picture. Now, how often does this happen? I believe, and through most of my reading, the research is showing that it happens an awful lot. But usually, the natural killer cells, and probably the cytotoxic T lymphocytes of the immune system, identify that cell as having a problem and kill it and just remove it, and so that it has no chance to reproduce. The ones that are dangerous are the ones that are still producing the correct MHCs and evade the immune innate or specific immune responses, and so can grow unhindered. So one of the problems with cancers is that they are you, like they are your own cells. They're your own cells that have lost control. There's a school of thought that says that when tissue is damaged, then the tissue that surrounds undergo pressure to undergo mitosis and replace the damaged tissue. This may require cells to kind of revert back to almost stem cell and lose a little bit of their differentiation so that they can differentiate into the cells that need to be replaced. And there's a school of thought that says that that's what's going on, that this is it's the body's attempt to repair damage gone awry that can cause these mistakes and cause these things to happen. If that's the case, then we are constantly undergoing this, and anytime there's a mistake in it, our immune system takes care of it, and it only turns into cancer in those very rare instances where it gets missed by the immune system. There's some fascinating research being done on that, and it's holding a lot of merit. It explains why my uncle, who smoked 2 packs of unfiltered cigarettes a day from the time he was 16 until the time he was 70, and he worked underground in an asbestos mine, didn't have lung cancer. And other people, work in a bar for a couple of years, have some secondhand smoke, and end up with lung cancer. It is, my uncle's ability to nip those things in the bud, his immune system's ability to not let any of those things grow, was exemplary. As far as his lungs went. He ended up with prostate cancer, but that's a whole other story. Okay, so when we talk about these tumors, there's 2 things. So from a clinical point of view, we have to know what's going to happen. Where does the tumor come from, and what's the normal course of it? What are we going to see? And so we grade tumors, and we stage tumors. So in grading, we're looking at how, is it benign or is it malignant? If it's malignant, how malignant is it? So we look at the histological characteristics of the tumors. And this is why we biopsy. This is why we send the tumor biopsies to pathology labs, and they look at it and they say, okay, the histological characteristic is this. So we're looking at how much anaplasia is, how much loss of differentiation is there in these cells. And then we look at, and we class this depending on how much malignancy there is seen. So if you've ever had a pap smear, it'll come back normal with all the cells being histologically correct. You may get a result that's, we're starting to see some abnormal cells. So there's a little bit of loss of differentiation. The histological characteristics have changed. Are they anaplastic? Probably not. So it's like, okay, this is something to be careful about. Maybe there should be something done about that. Or it might come back with, okay, these are definitely cancerous cells. We can see the anaplasia in it. And so therefore, this has to be either burned off or frozen off or cut out or whatever the treatment's going to be. And then we look at how malignant it is. So they'll start to look at the spread. Is it in the lymph nodes? Is it metastasized to someplace else? So you might need chemo or, those sorts of things. The same thing with breast tumor biopsies. Like it's a pretty standard story that they go through to grade the tumors, right? And then we have to find out the staging. The staging is where is it and how has it spread within the host. So we look at the tumor. Where is it? How big is it? How big is it locally? Has it gone into the lymph nodes? Has it metastasized to distal places? So, if there's a lump found in the breast and it's, they'll see it with a mammogram and they'll say, okay, it's so many millimeters. It seems to be local. Let's biopsy it. They biopsy it. They go, okay, it definitely looks malignant. So then, let's do a lumpectomy and let's take out the sentinel lymph nodes and see if it's in the lymph nodes. Oh my goodness, it's in the lymph nodes. Well, then we better do some chemotherapy, and because just in case it is starting to metastasize distally. You know, those are the sorts of decisions that are made based on this staging idea. The system that is most widely used is called TNM. And T stands for tissue, N for node, and M for metastasis. And so treatments are really governed by this. So if it's just located in situ in the particular tissue that it originated in, it can probably just be surgically removed, right? If it is starting to invade locally, we can probably surgically remove or shrink it with radiation, blast it with radiation. Now, what radiation does is the radiation causes the chromosomes that are condensed into chromosomes during mitosis to disintegrate, and then the cell dies. It targets anything that's in mitosis, and presumably the cancerous cell will be in mitosis more often than it's not, so the tumor can be shrunk that way. Chemotherapy is less of a local treatment and more of a systemic body-wide treatment that does the same thing. It targets cells that are in mitosis and hopefully kills them. To know how far to go with the treatment modality really depends on this staging system. So the grading happens from a biopsy looking at it under the microscope. Grade 1 is normal looking cells. Grade 4 is a fair amount of anaplasia, undifferentiated cells that have lost their typical look. So when we look at staging, we can look at stage 1 tumors that are small, they're localized, they're easy to treat, very good prognosis. By the time we get to stage 4, it is difficult to treat, it's metastasized to multiple sites, and it's poor prognosis. And it's kind of the stages in between. We'll talk about that more in a few minutes. So there's all kinds of acronyms. Here's one. Warning signs of cancer is caution, change in bowel or bladder habits, a sore that doesn't heal, unusual bleeding or discharge, thickening or lump in breasts or elsewhere, indigestion, difficulty swallowing, obvious change in warts or moles, nagging cough or hoarseness. Now, this is a pretty generic thing. So change in bowel or bladder habits is probably colorectal cancer. Sores that don't heal is probably some sort of a basal cell or squamous cell carcinoma in the skin. Unusual bleeding or discharge is probably got something to do with uterine cancer. Thickening or lumps can be just about anywhere, but it really is kind of pointing to breast. Indigestion, difficult swallowing is probably got something to do with pancreas or stomach, something in that nature. Changes in warts or moles is probably melanoma. Nagging coughness and hoarse is probably lung cancer. So you're not going to see all of these things in a specific cancer. So if you have lung cancer, you're not probably going to say the warning sign is a change in bowel or bladder habits, but these are things to be cautious about. That's why it's caution. In children, it is just paleness, prolonged tiredness. So it's children is children. So unexplained weight loss continued. Headaches, increased swelling, persistent pain in bones and joints. This is a big one for bone tumors, especially osteosarcomas. Oftentimes, the pain will be around a joint, usually the knee, and parents especially, will try to attribute it to something like a sports injury or something like that. But the pain persists, and it's usually quite hot to touch. Increased swelling, so it's very inflamed. Lumps, abdomen, neck, elsewhere. Although you got to be careful about that it's not just a inflamed lymph node. Whitish appearance in the pupil of the eye, recurrent fevers not caused by infection, excessive bleeding, excessive bruising. So that would be indicating leukemia, right? Paleness and prolonged tiredness is a more general sort of thing. So this weight loss and tiredness kind of is more general. This slide has kind of perplexed me a little bit. There's local effects of tumors. So when the tumor is in situ and taking up space, it's going to cause pain. By the time the tumor gets big enough, it's going to be putting pressure on nerve endings. It's going to be causing inflammation. It might cause ischemia, could cause bleeding. So ischemia is that it takes up so much space that it actually cuts off the blood supply to the surrounding tissues. And that's a painful thing. And that really kind of leads to this whole idea of obstruction. So compressing ducts grows inside a passageway or around structures, and compresses and obstructs the passageway. So a benign tumor even on the bowels will obstruct the passageway through the bowels. There can be tissue necrosis, ulceration, that might become infected. So there's an acronym for this. So it is patient often is weak and in bed. So patient is pain, often is obstruction, is infection, weak is weight loss, and is anemia, in is again infection, and B is bed. I don't know how useful that is, but whatever. Now, it's interesting, it's saying this slide says, what are the other two local effects? So pain and obstruction are big, but it's bleeding and ulceration, necrosis, are the other two. Although it's interesting that they put bleeding up in here and they put necrosis and ulceration in here. So the local effects are bleeding, pain, obstruction, ulceration, necrosis, as per your textbook. But they all make sense. The tumor takes up space, it's going to stretch things, it's going to press on things, it's going to cause inflammation, it's going to cause pain. It may obstruct the passageway of things. It will die in the center and will either cause ulceration if it's near the surface, or bleeding, necrosis. Those things all kind of just go together with the fact that the tumor is getting large. So loss of appetite is a big thing. Overall weight loss and generalized weakness is what you see. Like if you go visit somebody, a relative that has cancer, you're going to be, oh my God, like he used to be 190 pounds and now he's 105 pounds. Like you see that wasting away. And it happens because of a loss of appetite and an increased metabolic rate. And oftentimes a lot of vomiting, especially if they've been having the treatment, chemotherapy and radiation will cause that. So there'll be this generalized weakness and weight loss. People waste away. Immune system tends to be suppressed either by the cancer cells or by the therapies themselves. Oftentimes, bone marrow is suppressed. The chemicals that cause erythropoiesis and leukopoiesis and thrombocytes are disrupted, and you end up with anemia, leukopenia, and thrombocytopenia. So anemia is a lack of red blood cells, leukopenia is a lack of white, thrombopenia is a lack of platelets. Again, chemotherapy can be a real culprit in this. Chemotherapy targets cells that are actively undergoing mitosis. So bone marrow cells are actively undergoing mitosis all the time. And so they will be killed by the chemotherapy, presumably along with the cancerous cells. Hair follicles are undergoing mitosis at a rate, and they will die. Skin lesions are common because of it, and so are mucosal lesions. So you can end up with these problems just from the chemotherapy. Poor nutrition, if there's any invasion into bone, and a lot of metastasis goes to bone, will cause that. And so it becomes a real general sort of symptom. Leukopenia is deficiency in circulating white blood cells, malnutrition and chemotherapy. And then it adds to the problem of opportunistic infections because the host is immunocompromised. Infections can be very difficult to manage. And we can get these terrible things like bed sores become really infected because of a leukopenia coupled with poor nutrition, wasting and weakness, too much time in bed, chemotherapy preventing skin from regrowing properly over these lesions. It all can be very, 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 very difficult to manage. Thrombocytopenia is around blood clotting. And a lot of people with cancer actually die of hemorrhage, internal bleeding, and things like that because of the thrombocytopenia. Most of these things are managed through blood replacement therapy, through platelets, through whatever, through donated blood. The hair loss and mucosa inflammation is complications of these things because of chemotherapy and radiation, because these tissues are actively in mitosis a lot of the time, and that's the target of both chemo and radiation. There is something called the paraneoplastic syndromes, and these are interesting. When a cell becomes undifferentiated. When it loses the control that's going to make it differentiate, it really has the genetic capability of becoming just about any other cell that there is. Now, epithelial carcinomas will tend to become cells, other types of epithelial cells. So, like a squamous cell that's a type 1 cell in the alveoli of the lungs becoming cancerous might start to differentiate, because it's lost its way, into a glandular cell and start secreting cortisol, or start secreting adrenocorticotropic hormone, or aldosterone, or antidiuretic hormone, or any sorts of hormones, and they're being released exactly like they would be released from the glands that are supposed to release them, except it does it uncontrollably. There's no feedback that stops it. And so the cells can really start to mimic glands and really produce some very odd hormonal things, which will throw off homeostasis to the point that it will kill you. Less important kind of paraneoplastic. So I've seen tumors in pathology museums, ovarian tumors that are the size of a volleyball, that have hair and teeth in them, and because what was supposed to be ovarian cells have lost its way, and some of it thinks it's gums, and some thinks they're hair follicles, and it's really strange. I've had students report to me that they've had these tumors removed, and some of them have actually sent me pictures of the tumors. So it's a real problem with this loss of differentiation, that these cells can become other things, and probably affect homeostasis in a very negative way, and make people far more sick than the tumor itself and its space taking and its metastasis. Yeah. We'll end this presentation here and pick up in the next video.